Right. Well, thank you guys for joining. I'm Jessica Ballard. I am the Director of Development here at Lenape Valley. Jen Moran is our Director of Intensive Behavioral Health Services, and she is going to tell us a little bit more about that program and a new therapy that Lenape is going to be offering within the year called Parent-Child Interaction Therapy. She's got a lot of great information for us, so I'm excited to hear her. If we could just keep ourselves on mute. If questions come up during the presentation, feel free to type them in the chat, either to the entire group or just to me or just to Jen. And if there's time at the end, we'll be sure to answer any questions that you might have. We're also recording this, so we will post the recording on our website at lenapevf.org when this is over to make it available to folks who maybe can't stay the whole time or have missed part of it. So Jen, thank you so much for this, and we're looking forward to hearing.
Absolutely. Thanks, Jess. Good afternoon, everyone. Thanks for joining today. As Jess said, my name is Jennifer Moran. I am the IBHS Director here at Lenape Valley Foundation. And for those of you who don't know, IBHS stands for Intensive Behavioral Health Services. We recently just switched over from BHRS, Behavioral Health Rehabilitative Services. It's also known as wraparound to some people. So this department has just recently switched over to IBHS in January of 2021. And we are looking to add, and expand our children's services. And one way of doing that is by adding this parent-child interaction therapy. And we're really excited about it. And I'm excited to become one of the providers in Bucks County. So just a little bit about IBHS. Let me just click the side here. Lenape Valley's IBHS program is designed to provide a broad network of support for families of children who struggle with mental and behavioral challenges. The IBHS team works within the community, the school, and home environments, which help families connect to various challenges within the context of the home. The goal of IBHS is to help the family create a positive, supportive, and stable environment that will enable the child, youth, or young adult to get the most out of any clinical care they may be receiving and develop positive behavior management strategies that will allow them, the child, to reach their full potential. So we have a broad network of a team involved with the IBHS service. So we have a behavior consultant, a mobile therapist, a behavioral health technician, an administrative team, which includes administrative coordinators, clinical directors, and the director. The IBHS service is delivered by a team of varied specialists, including the ones that I just mentioned, and the administrative staff are also involved on the back end of things. They do more of the office of making sure that everything is up and running the way it is supposed to be, which is great. So we're just going to take some time and kind of go through each of the team members so you can have an understanding of what each one does. The behavior consultant serves as a consultant to the mobile therapist and or the behavioral health technician if they are assigned to the case. So you don't need all services assigned. You might have one or the other. However, if there is a behavioral health tech that is needed, a BC needs to, or a behavior consultant needs to be assigned as well. The behavior consultant works with the family and other members of the treatment team, such as school, to design and direct a behavior modification plan that will meet the needs of the child and family. The BC works primarily with the caregivers, so that could be anyone that's primarily taking care of the child, whether it's a school teacher, camp counselor, grandparents, foster parents, adoptive parents, aunts, uncles. But the BC also provides assessments, program designs, and monitors the treatment interventions to make sure that they're working. And if they're not working, then they have the ability to redesign that treatment plan. Then we have the mobile therapist. The mobile therapist will identify the needs and strengths of the child and family. They provide individual and family therapy to the child, generally delivered within the home setting. They can go into the school and community if needed, but typically it's just within the home setting. The mobile therapist will listen, ask questions, and provide clinical information to help the family. They assist the family to promote independence in managing mental health needs or behavioral concerns that they have. The behavioral health technician, they carry out the specific interventions that are on the treatment plan that the behavior consultant has developed. They provide more of that one-on-one intervention to the child alongside of the caregiver. And they're just working to acquire the skills necessary to manage the behaviors. So they're modeling and promoting age appropriate behaviors while they're working with the child or youth. The main goal of the BHT is to transfer the skills then to the caregiver and support the caregivers in providing those immediate rewards. Because in the end, these team members aren't going to be in there for a long time. They're not going to be there forever. It is a shorter term service. So we look to have IBHS in the homes with, on average, around 2 years. And we want to make sure that we're providing all of the treatment that is necessary for the caregivers to then follow up with those services when we're not there, even during the weeks when the team isn't there. Then we have the administrative team who work extremely hard and diligently to ensure that the IBHS is being delivered in accordance with state regulations, and while upholding Lenape's goal of promoting wellness, recovery, and healing. All team members provide interventions and activities that are consistent with the family's culture values as well. So if we are going into a home, we want to make sure that we're respecting the values and the traditions that the family wishes for us to. Next slide. So let's talk a little bit about the role of the caregiver. So as I said, the caregiver can be anybody that is participating in the child's treatment. So teacher, parent, any guardian. We want them to identify the strengths and the need of the child, the strengths and needs of the family as well. Participate actively within the treatment team, be present and available when the team is delivering services. So a caregiver, this is important to note that a caregiver must always be home when we are providing services, or a teacher must always be in the room when someone's providing services to the child. We want to ask questions. We want the families, to ask questions about any aspect of the treatment process. And the team will then answer them for you. And if they can't, then they'll come to their supervisor to get further clarification. We want the families to verbalize any concerns that they have, expect growth and recovery for their child and family, provide a safe and substance-free work environment. And if at any time, if a family has any concerns about the treatment team, they are encouraged to call the supervisor or myself of the program. Okay. So to access services, a family should contact our main office, and at the end, I have a slide that has all of the contact information for everyone. When they contact the main office, they should then ask for an intake for intensive behavioral health services. The family member will be connected with the intake team to complete registration and what we call a written order. In order to qualify for intensive behavioral health services, a child, youth, or young adult must also have medical assistance or Magellan Health Choices Bucks. If they don't, that's totally fine. We can help get you set up with that. And if the child is diagnosed to be on the autism spectrum and have commercial insurance, then we can also help them obtain Act 62 benefits, which allow for this service. The service is free. A written order is completed by a licensed professional who is qualified to complete it. They will gather identifying information as well as any behavioral emotional concerns that they deem necessary. So we have to meet medical necessity for this service. So when they're writing the written order, then they're going to look at all of the concerns that the family is bringing and try to get an understanding if it meets that medical criteria or not. The written order also suggests the amount of hours for the treatment team. So they might say that a behavior consultant should be in the home for 10 hours a week, or I'm sorry, 10 hours a month. So that comes out to 2.5 hours a week. But it's important to note for this that that's just a suggestion, and some written orders may have really high hours. Once the treatment team is established, they're going to go in there and they're going to complete what we call an initial assessment. And that's complete. And when that's completed, that determines the appropriate amount of hours needed for the service. Once we have that written order, a referral is made to our program, and we call the family to let them know that we have received it and what the next steps are. Once a clinician is assigned to work with the family, the first 30 days are for the initial assessment period. So the clinician will then complete an assessment, an individualized treatment plan, and once those are completed, they're submitted to Magellan for approval for the authorization, and then the whole team can be staffed. So if they are recommending a mobile therapist and a behavior consultant, after it's approved, we can then put both team members in there. An authorization lasts for 6 months, and every 6 months, a new treatment plan and assessment are completed to discuss any updates, any progress. Maybe there's regression. Maybe we need to add a new team member. Once a team is assigned, they will then begin to provide the interventions that are outlined on the treatment plan. And the family works with the team, whether it's the mobile therapist and behavior consultant, to write those goals. Because essentially we want to get an understanding from the families what they want to work on and the goals that they want to reach. And during the assessment period, all of those, the treatment plan and assessment are reviewed with the families to make sure that all information that we gathered is accurate. And then we have the families sign off on everything as well. Currently, it is important to note that we are not accepting any referrals right now for IBHS at Lenape Valley Foundation. But if you do need recommendations as far as other providers that are, I'm more than happy to help you navigate that. And we will make an announcement once we are accepting new referrals. Okay. So that is it about IBHS. And now we're just going to talk a little bit about PCIT, or parent-child interaction therapy, and do a brief overview of that. So this is something that I learned about probably 8 years ago when I was in my internship program, and I shadowed somebody that did PCIT, and I was just so excited to get the opportunity to watch this and watch how the families then improved and progressed through this treatment, and in such a short amount of time, what I thought was just a short amount of time. So we are going to just kind of go through the basics of PCIT. There's so much more to it that it could be, I mean, the training for it is a year long. So it's really just the basics of what it will look like. But parent-child interaction therapy, or PCIT, is an evidence-based treatment for young children with behavior concerns. It places emphasis on improving the quality of the parent and child relationship and changing the parent-child interaction patterns. In PCIT, parents are taught specific skills to establish a nurturing and secure relationship with their child, while increasing the child's pro-social behavior and decreasing that negative behavior. The treatment focuses on 2 basic interactions. So it's child-directed interaction, or CDI, which is similar to play therapy, and that parents engage their child in play situations with the goal of strengthening the parent-child relationship. And then there's also the parent-directed interaction, and that resembles clinical behavior therapy in that parents learn to use specific behavior management techniques as they play with their child. PCIT has been shown to effectively move disruptive behaviors in these children back to a typical range. Children learn how to control their problematic behavior, and parents experience much less stress in handling children. That can be challenging. The program is effective for children between the ages of 2 and 8. And it usually takes about 12 to 20 sessions weekly. What happens during a PCIT session is that parents and children are seen together. Parents receive live coaching from their therapist behind a one-way mirror via a wireless earbud as they lead the child through a series of tasks and practice specific responses to both desired and undesired behavior. So what that really looks like is a parent or a caregiver that's working with their child will have what they call bug in the ear. So they'll have a Bluetooth in their ear and they're in a room alone with their child where the therapist is on the other side of the two-way mirror coaching the parent as they're playing. So it looks different between the two basic interactions. So when it's child directed interaction, the therapist will share how to praise the child versus the parent directed intervention is where you're trying to have the parent then provide directives to the child and then learning how to communicate with them when they are having some avoidance behaviors. Outside of session, the parents are asked to complete regular brief practice sessions with their child under the guidance of their therapist. Home practice facilitates skill building and confidence in the use of PCIT techniques and strategies. The home practice is very important when it comes to PCIT and the success rate. We can tell in a PCIT session if skills weren't practiced during the week, which is understandable because there might be multiple kids or there might be a lot of just things going on in daily life. But it is important to practice them at home to have a better success with this. Okay. So again, let's just kind of look at how we can obtain PCIT. Right now with Lenape, we're not offering it at this time as I am still going through the training for PCIT, but it will be within the next year available. So similar to the intake for IBHS, family would call for an intake for PCIT, or if the family is already involved with Lenape, they can then ask their clinician the steps to take for that referral for PCIT. What's exciting is that a person or a family can have IBHS, individual services with the behavior consultant and mobile therapist, as well as having PCIT. So they're both very time consuming, but if the family has it available and it's warranted, we can do both. Once the referral is complete, the PCIT therapist will complete the pre-treatment assessment. And that consists of a clinical interview, observations of the client, of the child's disruptive behaviors and parenting skills. It's in a three-part parent-child interaction situation. So we watch the interactions over 3 situations and do an assessment with that. We also do the administration of the IBERG Child Behavior Inventory, or ECBI, which is just again, understanding the behavior of the child. We do an instrument for broad screening of child psychopathology, so more or less the diagnosis of the child. Intake is typically 1 hour for the clinical interview, and then it's an additional 60 to 90 minutes for completing the questionnaires and parent-child observations. It can be done in one session. It is difficult just because of attention spans from the child, but so it's typically completed in 2 different sessions. The ECBI is a 36-item inventory that provides information on the frequency of the child's behavior problems and the extent to which the behavior is problematic. Okay, so we're rating both of those, so the frequency and the severity. A significantly higher ECBI problem, it suggests that an intolerant parent who might benefit from parent education on developmentally normative misbehavior. I know that's a little confusing, but when you're in the assessment process and we get these scales, we go through it with all of the parents, what they mean, what and how we can address those behaviors. Let's see, a significantly higher intensity than problem score suggests a permissive parent. So again, when we see these scores, we can look at what type of parenting style we're working with, and then helping them find more developmentally appropriate skills and interventions to work with their child to promote that positive child outcome. The DPICS is observations, and so the observations that we're doing, those 3 observations that I mentioned, and then the ECBI data are collected at each session. So we're tracking the parent skills acquisitions and then the weekly changes in the child's behavior at home as well. So when we do the assessments at every session, we just want to make sure that as a therapist, we're staying on track with providing the appropriate treatment and the appropriate interventions during the session so we can have success with this. Okay. So some of the common presenting concerns that we'll get for PCIT are just some of the behavioral concerns that we're looking for. So we might see adjustment to blended families, abuse, low self-esteem, perfectionism, developmental delays, generalized anxiety, post-divorce adjustment, separation anxiety, disorganized attachment, non-compliance, verbal aggression, cruelty to animals, physical aggression, fire setting, lying, school conduct problems, stealing, hyperactivity, destructive behavior, and self-injurious behavior. Okay, I mean, that's just a few of them. That doesn't mean that somebody without any of these cannot also obtain PCIT. They just have to make sure that we're meeting medical criteria for that. Okay, so we're going to just talk a little bit about those 2 phases that I talked about, the child-directed intervention and the parent-directed intervention. So in the first phase, we call that the CDI, and that's when parents learn skills to strengthen the parent-child bond. It increases the child's pro-social behaviors and decrease the negative child behavior. Then we move on to the second phase, which is the PDI, or the parent-directed intervention, where parents learn additional skills to reduce the child's noncompliance and other negative behaviors that show resistance. Okay, so we also teach how to do a timeout in PCIT during the second phase. We have a timeout chair in the room, and if it's warranted during the session, then we coach the parent or caregiver how to put their child in a timeout successfully. So in CDI, parents learn to follow the child's lead in play. They learn to use specific types of positive attention that for most children function as positive reinforcement, describing and praising positive play behaviors and reflecting that appropriate talk. Parents also learn to avoid particular types of statements like commands or questions and criticisms during this time. That can be seen as intrusive and often give attention to negative child behaviors. The therapists actively coach parents to use differential social attention as they play with their child. That is, that we teach parents to switch immediately from positive attention skills to ignoring when a negative child behavior occurs, such as whining, yelling, backtalking, and to switch back immediately to the positive attention when a positive child behavior occurs. The new parent behaviors learned during CDI serve to teach children new skills, such as positive social interactions, cooperation in a play interaction that help the parent and child both enjoy them playing together. Throughout the child-directed interaction phase of the treatment, parents practice new skills at home with their child daily during a daily 5-minute session called special time. This treatment phase continues until parents demonstrate the mastery of all of the skills that they're being taught during the session. So then they're just going to go home and they're going to practice them for 5 minutes a day or 5 minutes weekly. So it's not a lot. And the positive new parent-child interaction pattern learned during this first phase of PCIT provides the foundation for successful implementation of the discipline strategies introduced then during this second phase of treatment. And most children show substantial reductions in noncompliance during that first phase of CDI, of treatment alone. So sometimes people will say, okay, great, like my child's doing great. I'm not seeing as much noncompliance. The tantrums have stopped. But that doesn't mean that treatment's over yet. We want to make sure that we continue on to the second phase so that we can then master those skills as well, because we don't want then if the families quit PCIT in the middle of it, we don't want them to then, just have those behaviors return. We want to make sure that we can continue to reinforce the positive behaviors that the child's displaying. Okay, so in the second phase with the parent-directed interaction, parents learn to lead and direct their child's behavior when needed. They are taught to use specific kinds of directions or commands that children are most likely to obey. Specifically, parents learn to give commands that are direct, age-appropriate, specific, positively stated, and given one at a time. So when you want a child to complete a task, we want to make sure that the parent is giving a direct task or a direct command versus saying, can you pick that up for me? Well, any kid can just be like, no, I don't want to pick that up. So when we say, Johnny, pick that up, then we're giving that direct command. And once they do it, then we can use those positive reinforcements that we were taught. Parents also learn to explain the reason for the command before the command is given or after it is obeyed, but not between those times. This timing helps to assure that the child will hear the reason, and it helps that the parents avoid reinforcing that non-compliance that might happen in between giving and complying with the order. To learn parental consistency in the discipline, parents are taught a specific PDI algorithm to implement when the context of the positive interaction is established in the child-directed interaction. When the child obeys the parent, it's taught to give very specific praise for obeying, to reinforce the child's compliance with that specific command that they're sharing. If the child does not obey, then the parent is taught to initiate the timeout sequence. After the parents master the basic parent-directed interaction procedures, they learn variations of the PDI for certain problem situations that may come up, right? Because not every situation is going to come up in the sessions that we have, and every situation is different. So to manage aggressive, destructive, or other behaviors that are difficult to manage within only running commands for positive behaviors, they learn to implement house rules such as no hitting. Standing commands are always in effect that lead directly to timeout if they are disobeyed. So we want to make sure that we are providing those interventions and those skills necessary if you should then have some non-compliance. Parents also learn and practice using the parent-directed interaction skills in public places. I'm sure we've all witnessed or have experienced when a child has a tantrum in public. What do? The embarrassment sets in, or you're just not quite sure how to respond to those behaviors. So all of these procedures and all of the practice of the skills at home and in the sessions, they can help you when you're in the public setting as well. Throughout the treatment, parents are given handouts that describe the procedures they learned so that they can practice in session, or learn from the session so that they can practice at home and review the procedures later as needed. As they say, practice makes perfect, right? So we want to make sure that we're providing any resources necessary to help you acquire the skills that are needed. And the more you do it, the better that you'll feel about, the more confidence the parents have. And then just overall, increasing that positive interaction between parent and child. Once PCIT is completed, we'll see that's completed when parents demonstrate mastery of both of those skills, so the CDI and the PDI. The parents report or caregivers report that their child's behavior is in typical limits on the scales that we give during each session, and indicate confidence in their ability to manage their child's behavior on their own. So again, it's those practicing that helps you get more confident in the skills. PCIT is a performance-based rather than time-limited treatment, meaning that treatment completion is determined by the progress of the individual family. So even though we say that there are 12 to 20 sessions, it all depends on the progress that we're making. So if we need to go over 20 sessions, we can. There is the average number of sessions they say is between 12 and 14 sessions, averaging about 60 to 90 minutes long. And the therapists are constantly working actively to keep families in the treatment until all of the goals are reached. So when we master and complete PCIT, there have been studies that show the outcomes of it, and they've consistently demonstrated increases in positive parenting behaviors and decreases in that negative parenting behavior after treatment. Children demonstrate significant reductions in noncompliance on the other disruptive behaviors, with gaining long-term success after the treatment ends. Additionally, parents report much less stress in managing their children's behavior as well. It helps enhance the child-caregiver relationship. Children's behaviors improve, especially the externalizing behaviors, the hitting, the tantrums. These improvements generalize to other settings and to other siblings too. So just because you have one child that is in PCIT, you can use the skills that you're learning for all of your kids if you need to. Improvements in child's behavior and family functioning have been maintained over 1 to 6 years post follow-up, according to the studies that have been demonstrated. So as I've said, it is an evidence-based practice. So they are studying PCIT outcomes and continuing to do so we can see how we can make this practice better and more successful. All right, so that is just a quick overview of PCIT and IBHS. What questions does everybody have, or if there was any posted?
I don't see any in the chat, but if Grace or Julie, if you guys have any questions, want to unmute yourself, you're welcome to. I think Jen, you have your contact information on the next slide too, if anybody wants to reach out to Jen with directly with questions or information, need more information about IBHS. Well, thanks so much, Jen. This was a great presentation. I appreciate all the information you shared with us.
Absolutely. Thank you.
For those who are on, we have another workshop coming up in July on unhealthy eating habits and eating disorders. It is later in July. If you check out our website, lenapevf.org/free workshops, you can get all the information for our monthly series. So thanks, Jen, and thanks for everybody for attending.
Thank you.